I want to talk about how to fix healthcare in the US, but not the way everybody's focusing on doing it. So I think there's been a lot of focus on having providers do this. The problem is that providers win on volume. That's how the business model has worked for a very long time. The sicker a local community is, the more money a hospital makes. This creates a problem because what we really want is improved outcomes. As hospitals and the provider ecosystem are trying to make money on transaction volume, they're also locked in this zero-sum game with insurance companies. So insurance companies are collecting premiums up front and trying to hold on to those, trying not to send those out to providers. So we've got bad outcomes that are leading to increased utilization. John Seddon calls this failure demand. This is when the failure of a system to produce the result it's supposed to produce puts more load back into that system. So this is going to build a circle, as I'm sure you've all predicted here. This increased utilization is leading to higher costs to the payers. The payers, though, have a lot of financial pressure to control costs. They don't want to keep raising premiums. So they're going to end up paying lower reimbursements out to the providers. Lower reimbursements for the providers probably means you're going to get less for a primary care visit. You're not going to get the time to spend to really deal with these clinically complicated cases, and you can't spend your time actually improving health outcomes. So then you've got worse health outcomes again. So everybody knows we need to break out of this cycle, break out of this transactional, episodic sort of model for healthcare. So people will talk about population health management, chronic disease management, even dealing with like the social and environmental roots of all these bad health outcomes. So we need to do all of these activities outside of this cycle. But this is the cycle the provider ecosystem has gotten good at delivering within for decades now. They're not good at doing population health management because of this episodic nature. They actually make the most margins, not on the routine preventive care that keeps people out of the hospital, but they make their money on the really intense complications, diabetic retinopathy, things like that. They also can't deal with social and environmental causes because they need to submit procedure codes to the payers to get paid for things. So what's the procedure code for extermination services or for grab rails for seniors with a fall risk? In order to do this stuff too, you have to build data feedback loops that can measure whether these things are actually effective. I'm not talking about the kind of reporting that dominates the industry. I'm talking about real analytics like we would know it from any of you who are from the technology world. They've also got data fragmentation on the provider side. So they've got EMRs, but it's a different EMR silo at the hospital from the one at the primary care doctor's office. We've had EMRs in some form or another since the 70s, but they've still never shared data. But I don't think tools are really the way to look at fixing this. I think you need business model innovation. The US already has access to the best technology in the world, and we still have this accelerating cost, and our outcomes are not improving. So my breakthrough idea here is that insurance companies should actively participate. They should identify care gaps using data, and then directly fill in those gaps in care, not recreate fee-for-service. So I think that part is really important. This is a world that software can eat. Software is not eaten in healthcare, in part because it's like indigestible right now. But if we can actually fix the business model, this is something that can operationalize, be measured, we can iterate, we can optimize. And now here I'm going to make the argument that insurance is uniquely positioned to be the ones to do this. So they already bear full risk. There's a lot of creative contracting that's trying to share risk, share savings. Insurance already has that risk. Every hospitalization you prevent from the payer side is one you don't pay for. That's the full cost you get to save. They've also got data integration already. You're paying claims for pharmacy, for hospital inpatient admissions, for primary care visits. You've aggregated all of the data that was in all of those siloed EMRs just by being a payer and by paying bills. You can also work across really large data sets. Your average payer, especially the big ones like United, Cigna, Aetna, they have large enough people sets that just dwarf what a primary care doctor would have. So they can do statistically significant analysis. And they can deal with social and other non-clinical interventions because they're not subject to having to justify clinical necessity to get paid for something like extermination services or those grab rails I was talking about earlier. So that's my argument for why health insurance is where innovation should happen to fix healthcare. Thanks. Woo!